If everybody would grab your seats again, please. As I stated, we're running a little bit behind, and we want to give Commissioner Reese due attention to his budget and his presentation. And Commissioner, if you're ready, we're ready.
Chairman Parrish, Senator Hill, members of the committee, we appreciate the opportunity to be here this afternoon to present the governor's recommendations for the Department of Community Health fiscal year 2014 amended and fiscal year 2015 budget. We're going to talk about the 2014 amended budget. We're going to talk about the current budget, then the amendments. We'll talk about some Medicaid and peach care trends. We'll go over our amended budget recommendations for 14, the budget recommendations for 15, and then at the end we'll talk about the state health benefit plan for a few minutes. Let's take a look at the current budget for the Department of Community Health appropriated for 2014. As you can see, the largest element of our budget is the age, blind, and disabled population in Medicaid. We have, and these pie chart items are state funds only, but you can see that we have approximately in Medicaid almost $13 billion budget. Almost $3 billion of that is state funds. So as I said, you can see here the different components that we have. We have adult, blind, and disabled, and our next largest element is low-income Medicaid. Then you can see the various elements of the department. We have a very small, compared to our overall budget, administrative expense. And then you can see the attached agencies, those smaller agencies that are administratively attached to us. I'll just mention in the healthcare access bucket, that's $6.7 million. That includes health information technology, the Office of Rural Health, and contract with Erlanger in Chattanooga. That's part of the healthcare access. We'll go over to the next page and look at the beneficiaries of our programs. Just about 1 in 4 Georgians are beneficiaries of DCH programs. You see about 1.59 million Medicaid members. That's about 65% of the total. About 45.19% of that is low-income Medicaid, and then 19.89 is the ABD population. We'll talk in a few minutes about the cost associated with each of those. You see Peach Care for Kids is around 219,000 children, and then we add in the state health benefit plan with a little over 630,000 members. That takes you to almost 2.5 million members served by the Department of Community Health. We wanted to show you how much reach we have with Georgia's children. Just about half of Georgia's children are served by a Department of Community Health program. We have for Medicaid and Peach Care, we have about 42.4% using a total children population of about 2.848 million. And then we have SHBP dependents, around 4.48% for 46.88%. And just to break out the number for Medicaid and Peach Care, we have about 982,000 on Medicaid and about 224,000 for Peach Care, and that does not reflect a shift required by the Affordable Care Act from children from Peach Care into low-income Medicaid that I'll talk about in a few minutes. Now we wanted to show a couple of slides to talk about trends. So you'll see here, and I think everyone's pretty familiar with this, the fact that about 29% of our members are in the ABD population. However, they're almost 60% of our cost. You'll see 71% of our members are in low-income Medicaid, but they are only 42% of our total cost. Wanted to have a couple of graphs to show you how Georgia ranks among southeastern states. These are all southeastern states, sort of where we rank. We are second lowest in the Medicaid recipients per 100,000 population. You see there we're about 19,306. Louisiana is by far the highest at 27,211 per 100,000 population. So the average is about 21,570. We go over to Medicaid expenditure per capita. Georgia is the second lowest. We're at $831 per capita. And you see Louisiana is at $1,522. So we just wanted to give you some sense of where we are in those two areas. Now I'd like to highlight, talk a few minutes about some of the initiatives that the 2014 budget brought to light. One that I'm actually very proud of and very pleased about is a decision to move the medical care for kids in foster care and for those receiving adoptive assistance and selected children in the juvenile justice system from fee-for-service Medicaid to managed care with, we chose AmeriGroup, one of the CMOs, to provide that care. During my tenure at the Department of Human Services, it was very clear that the medical care and the medical services and the continuity provided to these children was sporadic and spotty at best. They would be taken out of their homes, they would be put in numerous placements, their medical records would not follow them. Physicians did not know what prescriptions, what drugs they were taking. Sometimes they'd lose time in school because of the lag in information being transmitted to a medical provider or to a school. So we believe very strongly that the move from fee-for-service Medicaid to a managed care organization will give much greater continuity of care to these children and really provide a much sort of a medical home for them. We were trying to roll it out beginning January 1 of this year, but we wanted to make sure we did it right, because whenever you do such a transition, there are going to be glitches. And I wanted to make sure that when we rolled it out, it was successful and we had as few glitches as possible so the confidence level will be high, because if we can do this right, it will really help the children in this population. We also, I'm sure many of you are familiar of the Medicaid redesign effort that the Department of Community Health undertook in the last 3 or 4 years. The Navigant study, I'm sure many of you saw that. And I think the basic gist of that was that the state moved the ABD population, the age blind and disabled, into full-blown risk-based capitated managed care. And we've made a decision not to take that full-blown step at this time, but to take an intermediate step to establish a care coordination program where we have put an RFP that is out as we speak on the street, where we're trying to get a single statewide vendor to provide care coordination and enhanced case management for the age blind and disabled population so that we can try to control the cost of that population. These are folks with very high acuity levels. We're interested in seeing what proposals we get back. The proposals are due at the end of February of this year. We don't think that there'll be an initial net savings until we get some sense of how many people will enroll in the program. It will be a voluntary program, but we think over time we will begin to see savings in trying to have a better coordination of care for this population. So that is something, one of our major initiatives. We also have quite a few things that are required by the Affordable Care Act. There is a federal premium tax that is part of the financing for the Affordable Care Act that begins in fiscal year 2014, and I'll talk a little bit about it later, where we begin to pay that in fiscal year 2015. There is a requirement that we transfer children the ages of 6 to 18 who are within the federal poverty level of 100 to 138% from Peach Care to Medicaid. So there's a cost associated with that we'll talk about. The Affordable Care Act also provided that for the period January 1, 2013, the 2-year period ending December 31st, 2014, there would be a primary care physician reimbursement rate increase to match the Medicare rate. So that's something that we've been working on, and that will be an expense. It also requires us to change the eligibility review period for low-income Medicaid. We had been doing that every 6 months. The requirement is that we stretch that out to 12 months, so there's going to be a cost associated with that, on the theory and the rationale that if you had found someone at 6 months that was not eligible and you had taken them off the rolls, there would be some savings. If you don't analyze that eligibility until 12 months, there may be some people who were on the rolls in that ensuing 6-month period who may not have been eligible at that time, so we've associated a cost to that you'll see in a few minutes. Let me talk first about the fiscal year 2014 budget recommendations for Medicaid. You see here we have a figure associated with the item I just discussed, increasing from $9.7 million to account for the stretching out of the eligibility reviews from 6 to 12 months. We also, there is a, with regard to the primary care physician rate increase, There's an associated state insurance premium tax that goes with that. And there's a state portion of that, which for 14 amended is about $2.1 million that we will have to pay. The primary care rate increase is 100% federally funded, but this portion the state is required to pay, and so we have that here. You'll also see an increase in funds for what we are calling the woodwork effect. Even though Georgia is a state that has decided not to participate in the Medicaid expansion, we believe that there are going to be additional people who are eligible for Medicaid under the current eligibility rules that for whatever reason have not applied for Medicaid in the past, but with the advent of an online application, which we have put into place with our new eligibility system that we're working with the other state agencies, including the Department of Human Services, to implement, we think that there will be additional people who take advantage of some of these electronic methods for applying for health insurance, and that will be reflected in an increased cost. And then the number that we have here actually is a calculation of trying to determine those children who are going to move over from Peach Care to Medicaid, and this is a figure associated with that. This figure may actually be larger if we don't really know yet how many people will come, quote unquote, out of the woodwork. As you know, the federal exchange and the technology has had some challenges, so we don't really know yet how many people through the federal exchange have applied for Medicaid. Those were theoretically going to be transmitted to us through our eligibility system, which, by the way, is working well, and to determine how many people would be adding to the rolls. But we're hopeful that we'll know soon, but that will affect this number, and that is an item that is within this subject matter. And then there is an increase in funds necessary for our MMIS system. We pay based on a per member per month system, so if we have additional members in Medicaid for whatever reason, then that will be reflected in the amount that we pay our vendor, Hewlett-Packard. We'll go over to some other areas we have here. Number 5, a savings that will come as a result of some updates and some technology upgrades to our MMIS system that will allow us to more accurately determine what we should pay for physician injectable drugs. Right now, sometimes it's hard to tell if they're using the drugs in the units that we're actually being billed for. This system upgrade will allow us to do a better job of that, and we're projecting a savings of $342,000 to reflect that. In our age blind and disabled, low-income Medicaid, and Peach Care, we've adjusted funds here for growth. The growth in this year was not as great as anticipated, so this allows us to back out $20.1 million. We have next in our Indigent Care Trust Fund an amount of a little over 14, or a little less than $14.5 million to reflect matching funds for all private deemed and non-deemed hospitals that we will pay through our DISH program. Number 8 is an increase in hospital provided payment revenue for up to the upper payment limit for private hospitals. As you know, last year when you passed a continuation or an extension of the provider fee, for the first time we're allowed to pay upper payment limit payments to private hospitals. So this is a figure to reflect that. There's an effort to, with the Department of Corrections, for those individuals who are aging and sick in the prison system, to parole them out to private nursing homes. And in doing so, there would be those persons who are now being paid for through the Department of Corrections budget, through their medical budget, would be paid for through Medicaid. So this is a cost to reflect that. Then, with regard to the moving of the foster care kids and the adoptive assistants and the juvenile justice from fee-for-service to managed care with the AmeriGroup, we have adjusted the budget to transfer funds from the Department of Behavioral Health and Developmental Disabilities and the Department of Juvenile Justice to our budget to reflect our going forward administering that program for those kids. Then you'll see that we have to make a transition for number 11 in moving those kids off of fee-for-service into managed care, and there's a cost associated with paying run-out claims or run-out fees for the fee-for-service claims, and also there's a bit of staffing in here for 7 staff for 14 amended. Finally, on numbers 12 and 13, if you recall last year, the pharmacy and dental boards were transferred to the Department of Community Health. They were not transferred as attached agencies per se, similar to the Composite Medical Board or the Drugs and Narcotics Agency or the Georgia Board for Physician Workforce. They were brought over to community health as divisions at this time. So we have costs associated with trying to provide operating funds for those boards, and you see that reflected there at $1.4 million. And then one of our attached agencies, the Composite Medical Board, needs to implement licensing regulations for pain management clinics. And so we have a cost associated with that of $129,000. So total for fiscal year 14 amended, we are net asking for about $47.5 million in the governor's recommendation. We'll move over to 2015. Some of this will be continuation, so I won't go through the narrative explanations, but number one, this is a new item. This is the federal premium tax that's associated with the Affordable Care Act. This is one of the primary funding mechanisms for the Affordable Care Act. This is a tax on managed care companies and the business they do. This is not just their Medicaid business, this is their entire book of business, but there's a tax associated with it, and we will be paying this every September going forward at this point in time, with the first payment due in September of 2014, and that's a $29.3 million figure. The eligibility reviews, the 6 to 12 months for the full year, fiscal year 15. We just had a half a year reflection. We have a full year here for that change in the eligibility review. It's $28.2 million. We also are looking at that premium tax associated with the primary care physician rate increase, and for fiscal year 15, it's $1.1 million that the state will have to pay irrespective of the 100% federally funded rate increase. Now let me just say a couple things about that rate increase. It's the first rate increase for physicians in almost 10 years or over 10 years. It equates to about 15% rate increase. It goes back to January 1, 2013. We had to work with our MMIS vendor, Hewlett-Packard, to implement system changes to be able to reflect that and get those payments out. It's certainly true that we wish we could have done it sooner and smoother, but last November we began paying new day claims for fee-for-service for the primary care physicians who had given us the proper attestation that they were eligible for this rate increase. We've had to take a little longer to get CMS approval for both fiscal year 13 and 14, the rate increase, because anytime Medicaid changes its rates, you've got to do a state plan amendment, and then you've got to get CMS approval. That process has taken longer than we would have wished, but it's in place and we have approval for both of those changes. And so we're hoping that in the first few months of 2014, you'll begin to see, and my understanding is the new day claims for the CMO component, which is the much larger component of this primary care physician rate increase, will begin to flow. So it has taken us longer than we would have liked, but if you submitted the proper attestation prior to August 31 of 2013, your payments will go back retroactive to January 1 of 2013. So it's certainly our intent to make sure that all the dollars that the physicians are due will get to them, and we're trying very hard to get to a point where that money is going to begin to flow in a way that they need to see it. Then we have, for number 4, we have a larger figure associated with the woodwork effect for fiscal year 15 of almost $41 million. And then the MMIS fee associated with the additional members for fiscal year 15 is $1.69 million. You'll see on item number 6 for fiscal year 15, we have the same figure we put in 14 to move certain medically fragile inmates out of the correction system into private nursing homes, which will be reimbursed by Medicaid. You'll see an item here in number 7. This is to update the nursing home rates. This is a 3.3% rate increase, and nursing home rate reimbursement rates are based in part on a fair rental value system. And so this item 13.5 is to reflect that increase for fiscal year 15. We have a bit of a reduction for the MMIS upgrade that I talked about for the physician injectable drugs, where we're better able to monitor what we should be paying for that. So we backed out $680,000. We have a system called the Public Assistance Reporting Information System. This is item number 9, which will allow us to determine if a Medicaid, someone who we are paying now through the Medicaid system, might actually be eligible for VA benefits, or might actually be eligible not in Georgia but in another state. So we think we'll see some savings as a result of further implementation of this system, and we put in a figure of $2.6 million for that. And then you'll see we do cost settlements with hospitals every year. So we reimburse hospitals, and sometimes we're paying them more than we should. Sometimes we're paying them less than we should. We go back at the end of the year and settle up, as it were. So we always have a figure put in allowing us some money to be able to settle with hospitals as we need to. Last year in 14, some $5 million was taken out. This reflects the governor's recommendation to give us $5 million to account for what was taken out last year to allow us to make those cost settlements. We move over to number 11. This is a $44 million fund increase for growth for fiscal year 15 throughout Medicaid, age blind and disabled, low-income Medicaid, and Peach Care. We are fortunate to be able to back out some state funds to reflect an increase in the FMAP rate, going from 65.84% to 66.69%. So the federal government will pay a little bit more for our proportionate share, and this will allow us to, we think, save almost $70 million for fiscal year 15. We have the private deemed and not deemed payments for upper payment limits for the private hospitals for 22.5 for fiscal year 15, as I said, as a result of the extension of the provider payment fee. Then we have the transfer of funds from DBHDD and DJJ to reflect our administration of the managed care services through AmeriGroup for the foster care kids. And then the final item, number 15 on this page, is the run out for the whole 15 for continuing to pay fee-for-service claims for the current children in foster care. We have some administrative costs that we wanted to reflect for fiscal year 15. We have an adjustment for TeamWorks billings. The state has made some changes in the amounts paid for salary adjustments and the amounts paid for employer contribution rates to the employee retirement system. So this amount reflects that. Number 17, there was money put in the budget in fiscal year 14 to fund 2 startup federally qualified health centers in the state. That was a one-time appropriation, so it's reflected in a coming out for 15. That's at $500,000. We have the operating expenses for the pharmacy and dental boards of $1.4 million for 15. We have some employee recruitment and retention efforts and some merit-based adjustments for the entire department of around $198,000 that we put in for 15. Then we have an increase in funds to reflect an adjustment of the employer share. And within the State Health Benefit Plan, the Department of Community Health is an employer. And so the employer share has been increased, and a figure we've put in for us for that is $479,000. Then there are various items that are included in number 21. Part of that is to provide funding for 5 new family medicine residency slots at Gwinnett Medical Center in their graduate medical education program. We have 1 additional loan repayment award for the Physicians for Rural Areas program. And then we have the $129,000 that I talked about to reflect the Composite Medical Board beginning to license and regulate pain management clinics. So that is our recommendations, the governor's recommendations for Medicaid for fiscal year 14 amended and for fiscal year 2015. Now I'd like to move in and talk about the State Health Benefit Plan for a few minutes. As you know, the State Health Benefit Plan is a self-funded insurance plan that provides health care coverage to around 635 to 670,000. The number fluctuates. State employees, their retirees and dependents, public school teachers, retirees and dependents, and also school personnel such as bus drivers, cafeteria workers, et cetera. The plan pays an average of $10 million a day in claims. We strive to offer high quality, efficient, and affordable health care insurance to members while operating in a fiscally sound manner, and we'll talk a little bit about the difficulties associated with doing that. Before I talk a little bit about where we are now, how we got there, I would remind you that the plan has been through some difficult financial times in the last few years. When I left or was leaving the Department of Community Health as commissioner in 2010 to go to Human Services, the plan had almost an $800 million surplus. But that was used, and it needed to be, to balance the budget in other areas during the Great Recession that you heard the governor talk about this morning. So the plan has been through some difficult financial times. There was a point in, I think, fiscal year 12 where there was a pretty large operating deficit. I would like to commend my predecessor, David Cook, for doing a tremendous job of putting the plan on sound financial footing. This year we have a surplus, but there were decisions made and things put into place to try to account for not going back to an operating deficit in the plan, and I'll talk a little about that. But just to give you some flavor for where we were and where we are and where we're trying to go. The plan had reached the end of its cycle with the current vendors, United and Cigna, at the end of 2013, and the department went through an open competitive bidding process to choose new vendors starting for plan year beginning January 1 of 2014. That process culminated in the summer of this past year with the choice of Blue Cross Blue Shield of Georgia to be the third-party administrator and the medical manager for the plan. We chose Healthways to be the wellness vendor, and we chose Express Scripts to be the pharmacy benefit manager. There's no question that this is somewhat different and new for state employees and members of the plan. I can remember when the state health benefit plan had up to 6 vendors, each doing their own third-party administration. And we also, one change that was made this year, instead of having the third-party administrator subcontract for the pharmacy benefit piece and the wellness, which is a relatively new concept and a new initiative in the state insurance plan over the last couple of years, the decision was made to separate these out and to have separate contracts with Blue Cross, Healthways, and Express Scripts. So that is another new item for 2014. So what were the goals, what were the thoughts in trying to determine how we would move forward beginning January 1 of this year? One very important concept was to offer high quality, efficient, affordable health care. That's our mission, that's a part of the community health mission, and the state health benefit plan is a part of that. We were required to ensure compliance with the Affordable Care Act. There were certain requirements that all insurance plans, not just the state health benefit plan, but all insurance plans had to comply with regard to the actuarial value of what was offered. So we had to take a look at that. We also chose to offer the compliant plan designs in the gold, silver, and bronze categories, which would keep us compliant. We decided to institute an emphasis on a health reimbursement account as opposed to the old, well, we haven't had, as you know, indemnity plans for many years, but the HMO, the high deductible health savings account, the decision was made not to offer those and to go with gold, silver, and bronze health reimbursement accounts. One of the reasons is to incentivize and to allow people to take more of a ownership of their medical choices and how they utilize the wellness plan to account for certain expenditures they'd have and put more interest and emphasis on consumerism in the plan. And then you'll see there to promote more shared responsibility and consumerism through employees actually having consequences for what they choose to do or not do with regard to their health and utilization choices. And then also to seek to minimize premium increases for employees and for employers. Now, you've heard a lot about some consternation about some of the decisions that were made with regard to the 2014 plan design. So let me talk a few minutes about that. First thing I'll say is that if you have constituents or members or you yourself have questions about why some of these decisions were made, we have information that we have put together to provide to you, sort of frequently asked questions, sort of a concept, bullet points about why were some of these decisions made, what is the effect of them, what does it mean for 2014, et cetera. So we're happy to provide that to you. If you yourself or anyone you know or any of your constituents has a particular problem with implementation or transition or moving from United to Cigna to Blue Cross and Blue Shield, please bring them to our attention. We will address them individually, and we will seek to resolve whatever the issue is. And we've asked Blue Cross Blue Shield as our vendor to step up and help us do that. Now, we've moved from a copay system to more of a cost share system. This is where the insurance industry is going, but that's different than what our employees and what members of the plan have been used to. So you'll see that we were able to hold premiums, or even in some cases, if you had chosen the bronze plan, to reduce premiums, but it is true that the out-of-pocket costs are higher. So we put information out there so that members, we were hoping, be able to determine which plan they would choose as they try to determine what kind of premium do I want to pay, what kind of cost share and deductible do I want to have, understanding that the copay system, we're moving away from that. Now, I wouldn't expect everyone to have read all that and understand it completely, but as of January 1, we're faced with that. We go to the doctor, or we're trying to determine how we're going to plan for our expenses. So even though we put information out, education to help people, it's still incumbent upon us to continue to explain, to continue to provide information, to continue to try to help you with your constituents and to help individuals move forward to making the best decisions they can. The Board of Community Health always approves in August prior to the coming plan year, the plan design and rates. And I'll speak up for Blue Cross and say that this is not their plan design and rates or any vendor. It wasn't in previous years. United and Cigna, the State Health Benefit Plan, and the Board of Community Health and the staff of the Department of Community Health and the plan determine and design the rates with consulting help. And then we present them to the vendors and say, this is what we want you to administer. So if there's consternation and if there's anxiety about what was done, well, I have to stand up and own up to the fact that that is the responsibility of the agency and not the vendor. We've had some questions about why the Board of Regents Health Plan is so much better than the State Health Benefit Plan, and I think the short answer to that is that it's a different population. Your premiums and your deductibles and your all your revenues and expenses are based on the population and the utilization of services. The Board of Regents plan is much smaller. It's always been a much richer plan, but the population is different. So I think that's one short answer I would give. We've heard a lot about teachers are not happy with the plan changes. We would say somewhat in our defense that we have tried to provide, after the decision was made to go forward in this manner, tried to provide information to folks so they would make educated choices. But as I say, sometimes, you know, when you've been used to a system for a number of years, you go through open enrollment, you make a choice, but it doesn't really hit you until January 1 of that following year, what that actually means. We think we're seeing, going through some of that now. It's incumbent upon us, as I said, to be a full partner in making sure that everyone understands where we are. I'd like to show you the open enrollment results. Open enrollment was October 21st through November 8th of 2013, where you can make your gold, silver, or bronze choice. We thought that 50% of the members would choose the silver plan, which was sort of the middle of the road. You know, your premiums might not go down, but they wouldn't necessarily go up, stay the same. Your deductibles would not be as high as under the bronze. And we thought that the gold would be around 30 and the bronze 20. In actuality, 39% of the people chose silver, 42% chose the bronze plan, and 19% chose the gold. The gold is sort of the Cadillac plan. It's a much higher cost. The premium is higher, but your out-of-pocket over time is less. So I think we think that people were looking at the premiums and maybe not focusing as much on the cost sharing. And so we've got to deal with that situation at the present time. Now I will say, as with everything, we try to listen. and we try to hear what the concerns are, and we try to see, okay, how do we respond to that? So we have plan design and rates that are set for 2014, but what about 2015 and beyond? So there are things that I am willing to lead us to look at with regard to the state health benefit plan. A high deductible health savings plan, a HMO option. Those are things that we can certainly look at 2015. We need to try to be fiscally sound stewards of the plan so we can look at eligibility audits. Are all the people that are members, are they actually eligible? Are all the dependents actually dependents of our members? We can look at the contributing audits and some potential recoveries. Are we getting the payments that we're supposed to get on the employer side from those payroll locations? We can do plan summary claim audits and recovery. We can look at those really high dollar claims, trauma, transplants, hospital readmissions, coronary procedures to see that we're paying what we should be paying. Blue Cross has fully insured products. This is a self-insured plan. We can look at, how do we actually pay claims? How do we evaluate claims? Is there something we can do better? We can have better data reporting. We can require our vendor to have standards, performance standards and measures that we can look at to determine how can we save money through the plan, still be fiscally sound, still not go into deficit mode, but still be able to provide quality health care to our members. So these are all things that we are going to look at, we are willing to look at, and I hope you join me when people inquire. Please encourage them to contact me because I'd be willing to talk to them about some of the things that we're hearing and we're seeing and that we're willing to consider adjusting going forward. So, Mr. Chair, that's our presentation. We appreciate the opportunity. I'd be happy to answer any questions if I could.
Okay, Commissioner, thank you. Members, please do note that we have very limited time here because we do have to do the block grant hearings at 4:30. And I would ask Chair Lady Dempsey and Chair Lady Unterman if they would go ahead and be getting prepared for that. But anyway, our first question is Senator Fort.
Well, certainly, Senator, I would say it's never acceptable for anyone to die. I used to say when I was in the Department of Human Services that one child death is too many. So I would say the same thing here. I share the governor's concern about the fiscal impact of Medicaid expansion. If in fact we increase the rolls by 650,000 people, and for some reason at the federal level that 100% or 90% is not forthcoming, then the impact to the state budget would be devastating. So I think those are economic considerations, but how we provide quality health care through the resources that we are currently providing, that's just something we work on every day.
Quick follow-up, Mr. Chair. Isn't it true that the state would withdraw from that expansion at any time if in fact that 100% or 80% does not take place?
That may be true, but then the question is, what about those additional 650,000 people who are now on the roll, we would be required to fund them through the current 66-34%, and the Medicaid budget would explode.
Chair Lady Smith.
Thank you, Mr. Chairman. I'm over here. Thank you, Commissioner.
Thank you.
First of all, for our members, what can you get us a list of our contact people for like legislative liaison? Just some names where we can call in and not have to wait, because we're going to be responding to our constituents. So it would help to have a facilitated track for us. If
Yes.
that.
Well, the first name I give you is mine.
Okay.
If you get something to me, I'll make sure we respond to it.
The problem is
but-
getting to you.
Yes, but separate and apart from that, we can get you our legislative liaison, can get you a list of contact people, but I encourage you to feel free to contact me, because then I forward it on, and sometimes that seems to help.
Thank you. And then the follow-up really quickly is I'm getting questions. People are trying to understand how to offset the cost of their deductibles, because it's high in the different plans. If they incur cost in the first quarter of this year, how does it work towards a deductible they have to pay for a test or something like that?
Well, I'm not the expert that should comment on that, but we'll get that information to you. So I think we've talked about that in some of our frequently asked questions about what the actual procedures are, how you can best manage through your health reimbursement dollars, your medical care, and to sort of plan to the extent you can, not knowing that you always cannot. So I think we'll get that information out.
Thank you.
Thank you.
Representative Taylor.
Thank you, Mr. Chairman. Commissioner, I appreciate your being here and discussing and giving us so much valuable information. I've had many inquiries from my constituents, just like everybody in here. There has been concern about the Blue Cross limitations. I've explained that they still have the same choices no matter who the carrier was going to be. You were going to have the same type of program based on the Affordable Care Act. So most of them are accepting that, but we had some confusion with your PPO networks under Blue Cross and Blue Shield. I just want to verify and make sure that it is no way connected with what the Affordable Care Limited Network. My region has a very limited skinny network in South Georgia that does not apply to state employees. Is that correct?
That's right. The Blue Cross Blue Shield network through the State Health Benefit Plan is an open access network that is not the same network that they built or that they have put into the federal exchange. Those are two different networks. So we did comparison, and it's my understanding that 97% of the providers that were a part of the United and Cigna networks are now a part of Blue Cross and Blue Shield. We've had inquiries as to whether particular providers could get into the network when they weren't. When those have been brought to my attention, I've tried to put Blue Cross together with those folks so they could talk and try to work something out, and we'll continue to do that.
Thank you. That was my next question.
Sorry.
Thank you.
Thank you.
Okay, Commissioner, that seems to wrap up all the questions, and I thank the committee folks for being mindful of our time and the commissioner's time as well. Commissioner, we do appreciate you being here.
Thank you.
And thank you for the hard work you do. You have one of the most difficult jobs in my mind in state government and all that you have to handle. So thank you.
Sir. Thank you.
Ladies and gentlemen, the block grant hearings will begin at 4:30. If you, for some reason, need to step out during those, please be mindful that the DOT hearing will start at 5 o'clock. Thank you.